Speakers today, Siobhan Schabrun and Swati Mehta. Siobhan will go first. These are generally pretty short talks, and we have lots of time for informal discussion. So please feel free to ask many questions, and hopefully we get a bit of a discussion going. So our first speaker is Siobhan Schabrun. She is a professor in the School of Physical Therapy and the William and Lynn Gray Research Chair in Mobility and Activity. And I will let Siobhan take it from there.
All righty, thank you very much. So let me just open up my talk. So hopefully you see it fine, yeah?
Yes.
All righty. Okay, great. So thank you very much for having me today. So I'm just going to give a really short overview of the kind of work my lab is interested in. Most of what we do is focused on understanding, treating, and preventing the transition to chronic pain. So we work predominantly with non-invasive brain stimulation techniques. These techniques have been around in one form or another for a long time, starting in the 1st century with this fish. This is an electric torpedo fish. And these are the first documented cases of somebody walking along a beach, finding an alive electric torpedo fish, getting zapped and finding that the pain from the gout in their leg was somewhat improved. And this led to this host of experiments with these electric fish being used to zap heads for migraine and for headaches and for various other forms of pain. So 20 centuries later, we have moved on. Things are less slippery, things are a little bit more reliable. And we now use predominantly transcranial magnetic stimulation. And it comes in two forms. It can be used firstly as an assessment tool. So when we use it as an assessment tool, we use it in a single pulse format. So just one pulse at a time, a good 5 to 6 seconds between each pulse. We hold it over the head, and if the intensity of this stimulus is high enough, we will trigger the cells underneath the area we're stimulating to fire. That signal will travel down the corticospinal pathway, and it'll trigger a response in the muscle that we can pick up using EMG. We use the size of that response, it's called a motor evoked potential, to give us an index of what's happening in terms of neuroplasticity, whether the pathway is becoming more or less excitable. It can also be used as a treatment tool or as a tool to induce neuroplasticity. And here it's used repetitively at fairly high frequencies, usually between 1 and about 15 hertz. There are other forms of non-invasive brain stimulation induction tools, such as transcranial direct current stimulation, which is the one that you see here. So we can both use these electrical and magnetic currents to assess what's happening in the pathway and to try to treat or induce plasticity or changes in excitability in the pathway. So my lab is predominantly focused on TMS, but we also use other techniques. We use EEG. I mentioned we use EMG. We also are interested in quantitative sensory testing for various, to quantify various aspects of pain. In terms of patient populations, we work with two groups. We work with clinical populations, so people who are experiencing clinical pain, low back pain, neck pain, knee pain, for example. But we also use human pain models to induce pain in otherwise healthy individuals. We were able to better control the duration, the intensity of pain, and better control the other factors that sometimes contribute to pain. So things like psychosocial or other medical comorbidities. We use a range of different models, but the one that I'm going to focus on in some of the work I'm going to talk about today is repeated intramuscular injection of nerve growth factor. So for a really long time, the human pain models we had were very short lasting. So we could induce pain, but the pain would last maybe a few minutes, maybe a few hours, maybe 24 hours, if we were lucky, depending on the model. But NGF, when we inject it intramuscularly on repeated occasions, produces pain that develops slowly It peaks around day 4 or 5, and then it lasts out to 2 or 3 weeks before it starts to resolve. So it gives us this really nice temporal profile, if you like, to look at what's happening. In our case, we're particularly interested in the brain as pain develops, as it's maintained, and then as it resolves on the other side. Because NGF is involved in long-term sensitization of nociceptive processing and is thought to contribute to chronic pain, we also think this model has some mechanistic similarities with the transition from acute to chronic pain. And the symptoms appear to mimic those we see in chronic clinical pain syndrome. So things like spreading hyperalgesia, pain on function, and functional limitation. So my lab is interested in research questions across 5 broad areas. The first is trying to understand what works. So in terms of our current treatments, what's effective for who, when, and what isn't. Understanding who is at risk. So here we're interested in identifying and validating biomarkers that can predict the development of chronic pain. Understanding why some people recover from an acute episode of pain while others go on to develop chronic pain. So here we're interested in mechanisms involved in the transition that might help us to identify novel treatment targets. Can we improve clinical outcomes? And can we better translate evidence into clinical care? So I'm going to give you a couple of really brief examples in each of these pillars. So starting with what works. So my team has been involved in systematic reviews and network meta-analyses of various classes of muscle relaxants and analgesic medicines, trying to understand whether or not they have an influence on pain intensity. The overall take-home message is that there still remains considerable uncertainty about these medications, although they continue to be commonly prescribed, both regarding their efficacy and the safety. That's not to say that they don't work for everybody. In all of these group-level meta-analyses, there are some people that may benefit. There are many people who do not. And more work needs to be done to try to determine who is likely to benefit from these kinds of medicines. So we've also been doing a lot of work looking at who is at risk and trying to validate, in particular, a predictive cortical biomarker signature for pain. The biomarker signature is composed of 2 pieces. One is an EEG marker, which is peak alpha frequency, and one is a transcranial magnetic stimulation marker of corticomotor excitability. We selected these 2 components based on prior work that shows that they appear to have an association with the intensity and the persistence of pain. And in the first study we did in terms of validation was the analytical validation component. So getting a biomarker through to clinical implementation is a pipeline process. We have analytical validation that then moves to clinical validation, and then it moves to implementation from there. So the aim of analytical validation is to establish the performance and acceptable characteristics of the biomarker, reference ranges, and reliability. And in order to do this, we need to have a standardized, repeatable model. And this is where the NGF human pain model comes in. So we undertook full-scale analytical validation of our EEG and TMS biomarker in 150 people. We injected on day 0 and day 2. These individuals are otherwise healthy, and we injected into their masseter muscle. So this is a model of temporomandibular disorder or orofacial pain. We make measures of their biomarkers at baseline, so before pain onset, and again at day 5. And then we see what happens in terms of people's pain trajectories. We used machine learning approaches. We divided our sample of 150 into 100 people that were in the training set. We ran the models, we trained them, and then we locked them. And then we ran the best model in the test set of 50 people. And what we found, consistent with our preliminary work, is that if you are somebody who has a slow peak alpha frequency and low corticomotor excitability in response to pain, that you are someone who experiences higher pain in response to NGF. And we found that we could predict with very high accuracy. We had an area under the curve value of 0.88, who would be in the high pain sensitivity group and who would be in the low pain sensitivity group using these biomarkers. So the next step for us in terms of this work, which is beginning now, is full-scale clinical validation in clinical patient population. So along similar lines, we have also done studies trying to explore why some people recover while others don't. So this is the data from a prospective longitudinal cohort study of 120 people who experienced acute low back pain. They came into the lab within 6 weeks of pain onset, and we followed them up at 3 and 6 months after baseline testing. We looked at a number of variables, a number of biological variables, the key ones being corticomotor and sensory cortex excitability. We also took blood and saliva for genotyping and for analysis of other variables within the blood. And we took psychological and symptom-related measures. And we looked at all of these things to determine how many of them could predict chronic pain outcome at 6 months follow-up. I'm not going to talk about all of the different measures. I'm going to focus in on the corticomotor and sensory cortex excitability. And what we found is very consistent with what we saw in the preliminary work and in the predictive biomarker work. And that is that if you are somebody who has acute low back pain and you also have low corticomotor excitability, so here you're looking at transcranial magnetic stimulation derived maps for the paraspinal muscles. These are representative. So on the left here is somebody who recovered from their acute low back pain at 6 months follow-up. And on the right is somebody who developed chronic pain. And you can see that red indicates higher excitability. You can see that people with chronic pain have less excitability in the acute stage of pain. And that's reflected in the group level data that you see up here. We saw the same pattern for sensory cortex excitability. So here we evoke sensory evoked potentials. So we put a train of electrical stimulation into the paraspinal muscles. And then we look at the response using EEG at the level of the cortex. The red trace here is chronic, someone who developed chronic low back pain. And the black trace is somebody who recovered. And again, we see the same pattern. If you are somebody who has low excitability in the acute stage of pain, you are much more likely to develop chronic pain at 6 months follow-up than if you are somebody who has high excitability. So from these data, we believe that low sensory motor cortex excitability in the acute stage of pain is a prognostic risk factor for the development of chronic low back pain. And this starts to give us some mechanisms for which we can think about developing targeted interventions. So if you have low excitability in the acute stage of pain, and perhaps we can bring it up therapeutically, we can raise that excitability, perhaps there's a possibility that we might be able to reduce chronic pain or perhaps even halt the transition to chronic pain in the future. So this is an area that we're interested in, this idea of could we use in particular non-invasive brain stimulation to alter cortical excitability to deliver better clinical outcomes, to confer some sort of therapeutic benefit. There's lots of ways to do this. One is through repetitive transcranial magnetic stimulation. Another is transcranial direct current stimulation. And there are others, which I'm not going to get into today. But you can see here that we're not the only ones that are interested in this idea of being able to manipulate cortical excitability in order to improve not just clinical outcomes, but it's also being investigated in terms of performance outcomes, cognitive performance and physical performance. So we did a preliminary study where we looked at individuals with knee osteoarthritis. We gave an 8-week intervention that combined anodal transcranial direct current stimulation with standard exercise therapy for knee osteoarthritis, so muscle strengthening for the quadriceps and surrounding muscles. We had both an active condition and a sham TDCS condition. And here on the left, you see change in pain after the 8-week intervention, and on the right, you see change in function. The purple is the active TDCS intervention group, and the blue is the sham TDCS intervention group. The dotted lines are the minimum clinically important differences for these outcomes in knee osteoarthritis. You can see that exercise was above the MCID for pain, which is expected. We know that muscle strengthening exercise is moderately effective for people with knee OA. But what you can also see is that when we added the active brain stimulation on top of it, the changes in pain and function were much greater than exercise alone. And so next steps for this work are full-scale randomized control trials to determine whether the effect holds. And it's also becoming more and more possible with these kinds of non-invasive brain stimulation techniques to individually target them. So to do things like online adjustment of parameters to changes in cortical excitability in real time. So there's considerable technological advancements happening in this field. We're also exploring repetitive transcranial magnetic stimulation as a preventative tool. So if we give 5 consecutive days of rTMS before pain begins, does it have an impact on pain trajectories? And in this study, we are using NGF to induce pain. So we give 5 days of rTMS, then we induce pain, and then we look at the impact on the pain profile over time. Here, the orange group is the sham group, and the blue group is the active group. You can see that the group who get active rTMS have less pain over time than the sham rTMS group. So perhaps there's something to be explored here in terms of whether or not rTMS might be useful as a preventative, or perhaps it might be useful if it's given very, very soon after pain onset. Further things to explore for the future. Finally, our team is interested in developing integrated models of care, and this is work that's being led by Mulugeta Chawla, who's a CIHR Ready Fellow with my team. And he is looking first at a scoping review of understanding what integrated care for adults with chronic musculoskeletal disorders look like, and then progressing to an understanding of the various perspectives of all the different stakeholders, with a view to eventually co-designing a more fulsome integrated care pathway for people with musculoskeletal pain, and then testing that against kind of the standard or usual care in an RCT. So we have lots going on. That's obviously just a really brief overview of little pieces of the puzzle across all of the pillars, and some future directions for where we're heading. Of course, a huge thank you to my team who lead most of the projects that I've presented here today, and of course the funders who make it possible. Thank you very much. I hope that gives you a kind of taster of the things that we do. I'm happy to answer any questions you have.
Great, thank you, Siobhan. We'll take questions, and feel free to also put questions in the chat if you're shy about coming on your microphone. Dave has a question.
Not shy at all. Jumping right in. Yeah, I love what you're doing, Siobhan. I've got just some questions for my own interest here, and there's 2 questions. So maybe I'll ask the first one. When you've done the work looking at the corticomotor excitability or the alpha waves, as far as predicting outcomes, so predicting recovery trajectories, you say I know you're also collecting other sort of biological as well as psychological and social data. I'd be curious in knowing what is the predictive accuracy of those cortical indicators versus maybe some of the others. Like, I tend to find the psychological things often tend to be the most predictive of recovery, but I'm just curious what you're finding.
Yeah, it's a great question. And I didn't present that today just in the interest of
Mm.
time, but we have that information. So for the analytical validation study, we ran both the models using just the cortical biomarker alone, and we ran it using all of the other variables that we collected. So there were psychosocial factors in there, age, sex, gender, etc. What we found was that the model using the biomarker alone had higher accuracy than the model that used the other factors.
Mm. Wow.
Caveat is that that study was obviously done on healthy individuals using a pain model.
Right.
It remains to be seen when we roll it out in clinical populations where psychosocial factors might be expected to have
Right.
perhaps a higher, might contribute more to perhaps the overall recovery trajectory, whether that pattern holds. So stay tuned for
Okay.
the answer in patients.
Yeah, that makes a lot of sense too. And I guess on that same topic, like you mentioned that we're getting closer to using transcranial stimulation as a treatment technique. Are we anywhere close to using it as part of a potential kind of routine clinical evaluation? Sweet.
Depends what you mean by close.
Okay.
um, so at the moment, it's not, there isn't enough evidence to suggest that it would be useful as an assessment tool. If the biomarker work holds, so if we take this biomarker into clinical populations and we can predict as accurately as it appears we can in a model, then the next step, I think, is to refine the analysis pipelines, refine the collection pipelines to be feasible for use in the clinic, and then consider it for rollout. But we're some years away from that. There are obviously some steps that we need
Right.
to do to prove that it would be worthwhile putting into a clinic.
Okay, good. I will stop my questions there. I'll let others have a chance.
Sure.
Thanks.
Yes, go ahead, Joy.
I'm going to ask you a really difficult question, and I apologize for that
No worries.
because you cannot change the world. But thinking about the really exciting work that you're doing, and I think it's fabulous, and it really helps us understand how pain evolves. But thinking about forward to practical applications, thinking about when we have a situation where 40% of people don't have a family health practitioner, rehab costs money. People, most of it's moved into private practice, and people are being seen for 20 minutes on visits. How do you translate this kind of work into what is increasingly a very challenging healthcare system for people with low back pain?
Yeah, I mean, I think there's slightly separate pieces in the sense that the challenges with primary care exist not just for those with low back pain, but for anybody facing any kind of condition. And that is absolutely a challenge. I mean, if we can't get people to primary care, we can never implement half of the things that we would like to. Particularly, it's a problem for early detection, right? So having a biomarker but being unable to make the assessment of the biomarker until the person is chronic doesn't assist at all with prevention or better treatments or any of those things. I don't think that means that we should not keep trying in terms of developing the biomarkers, making things, putting structures in place or discoveries in place that would lead to prevention or to better treatment if the care systems could be tackled. And I guess we hope that at some point in the long run, maybe it's a fool's hope that money will go into healthcare, governments will prioritize healthcare, and it will get better. Maybe it's a false hope, but yeah, it's a tricky one for sure.
All right, I'm going to ask you one more question then, since nobody else is stepping up. I'm just curious, I'm back on this whole thing about how can we use this sort of translation into clinical practice, if we didn't have the technology, are there, I guess I'll call them clinical proxies or indicators that might kind of signal that there are corticomotor excitability problems in a patient? Like what might we see of, like, clinically?
The short answer is no.
Okay.
And that's because what we can pick up behaviorally is so much more complex and is the product of so many more interactions than just the change in excitability. So I guess what we'd be thinking about if we're talking about something like corticomotor excitability would be some sort of motor behavior, some kind of motor adaptation. We have a postdoc, Arnaud Duport, who's he's about to run a very large study using NGF, again, 150 people, looking at, can we map changes in corticomotor excitability to specific motor strategies? It's unlikely that it's going to be quite that simple.
Mm-hmm.
I think that we'll be able to get a good proxy, just again, because what's coming out in terms of behavior is the integration of so many things along the pathway, right? The cortex, the spinal cord, the muscle. And there's a contribution of psychosocial factors in there too, right? Movement avoidance and fear and these things. So I think the short answer is no. It's a little bit like having a good blood biomarker for something that might tell us the state of disease doesn't directly translate into what we might see behaviorally. It's kind of like a gap is too big.
Yeah. Okay. Yeah. I was hoping for the easy shortcut.
Yeah, us too.
Yeah, I'm sure.
Yeah.
Awesome. Thank you so much. That was terrific.
Of course. No
Great.
worries.
Yeah, thanks so much, Siobhan. We'll move on to our next speaker. So Swati, if you want to load up your slides. So then our next speaker is Swati Mehta. She is a scientist and a registered psychotherapist and has asked me to leave the introduction at that. So over to you.
Thanks, Dave. I hope everyone can see my screen. Perfect. As Dave mentioned, I'm currently a scientist across town at Parkwood Institute, and really the goal of my lab is to conduct impactful research that empowers individuals to self-manage their chronic health condition. And how do I achieve my goal? I think, first of all, we really need to evaluate, kind of looking at demonstrating how the interventions that we're delivering are effective at improving clinically relevant symptoms. And in terms of interventions, I've developed 3 main digital health programs that target the needs of those with chronic pain, secondary to neurological conditions such as stroke and spinal cord injury. So those are my primary populations of interest. And just looking at some of the effectiveness data that's come from these studies, we've generally found significant reductions in symptoms such as pain interference, disability, depression, and anxiety through those digital health interventions that we're providing. But is that enough just to concentrate on clinically relevant symptoms in order for our research to be impactful? I think in case of those with chronic pain, patients are often looking for a medical cure for their concerns. And unfortunately, that's not usually possible. There's no ultimate cure that we can provide to patients and kind of let them go and live their lives. And so those with chronic health conditions are individuals that kind of have these conditions for the rest of their lives, especially those in my population who have sustained a neurological injury such as spinal cord injury or stroke, and are experiencing chronic pain secondary to this. And so this really requires long-term management of multifaceted factors that target the needs of the population in order to improve quality of life. And so having mentors like Eldon and Dave who really take a look at a big picture chronic pain management that's multifaceted, I really wanted to expand the idea of effectiveness research to impactful research. And there's lots of different ways that we can kind of make research impactful. But for me, I really felt passionate about including things like engaging knowledge users, integrating knowledge translation plans, evaluating long-term maintenance of healthy behaviors, incorporating strategies for disengagers, non-responders. And so I'm going to talk a little bit about how I've incorporated these research design into my research as well. And so first, I wanted to incorporate various perspectives and needs into the research design process, really taking a look at a holistic transdisciplinary approach through engaging knowledge users throughout the research process. And I really did this by incorporating a lot of the evidence and lessons we've learned from patient-oriented research on how to ensure that knowledge users' voices are heard throughout the research process. And this included engaging with interdisciplinary group of frontline clinicians, funders, persons with lived experience, family members, and administrators. These individuals often don't have research backgrounds, so really developing supports and tools for training knowledge users in research methodology. And through this process, my lab now has a patient-oriented research committee that meets every 2 months to kind of go over the lab's research goals and activities and guide our priorities and everyday activities. And I've used a participatory action approach to kind of co-develop these digital health interventions I mentioned. And over the last few years, my research has really looked at patient and user perspectives of these digital health programs, how they're delivered, and even the web platform that we use to deliver these programs to ensure kind of the usability and adaptability to meet the needs of the community. Another component of research study design that really aligns with me is integrating knowledge translation activities throughout the research process. So really training and working with Eldon and Dalton and Bob Teasel on systematic reviews and clinical practice guidelines, I really started to see that demonstrating effectiveness or impact of an intervention isn't necessarily enough for it to be implemented into practice. So we really need to incorporate KT plans from the inception of the project in order for them to be successfully adopted and sustained in the community. And this really links back to ensuring knowledge user engagement as well as involving them in the IKT process. So usually in parallel, when I'm evaluating effectiveness of my digital health interventions, I'm also conducting research that evaluates barriers and facilitators for implementing these interventions. This allows me to guide strategies for long-term uptake and adoption. So previously, I conducted an evaluation of the implementation barriers and facilitators of my online digital health interventions in a hospital and a rehab community setting. And I found that patient and clinician perspectives of online programs, costs of delivery, integrating programs into hospital settings were really challenging barriers to implementation. And so thinking about these factors for implementing in a hospital setting, it meant changing things like electronic databases for referral processes, really working with hospital risk and privacy and IT departments. It also means working with frontline clinicians because it's an extra step for them to educate patients about the new program and how to refer them to the program. And then when thinking about implementation, I also wanted to raise awareness about my program. So really incorporating clinician and patient-led workshops that demonstrate the effectiveness, safety, and accessibility of the features of the program to improve acceptability and perception of these digital health programs was very important. The other thing was implementation also meant funding and finding supports for that program. And to me, I think it's an important piece. And I think kind of the conversation we had previously was, many programs get adapted by private organizations that kind of charge a lot of money and create greater inequity in access to these health interventions. And I wanted to ensure that if we're showing that a program benefits the community, we should be able to provide access to that population through a sustainable approach. And so recently, through a small grant through the Neurotrauma Care Pathways, I conducted a pilot implementation of my internet-delivered cognitive behavioral therapy program at 2 hospital settings. So here at Parkwood and at Hamilton Health Services. And this really involved developing a care map and a referral process for both institutions in their inpatient and outpatient setting. And so working with the site implementation teams and persons with lived experience, we created a clinician education videos, information brochures, and a referral process for guiding patients and care partners into our program. And then here at Parkwood, the implementation was led by spinal cord injury social workers. Implementation of the program involved providing patient education about what cognitive behavioral therapy is, how it differs from traditional talk-based therapy, how it can be used to develop skills to cope with distress and self-manage their chronic pain symptoms. We also provided patients with brochures in their patient binders and integrated referrals to the program in discharge notes. So far, we've been finding about 75% of patients have received this patient education and brochure. And in terms of sustainability of our online program, we've kind of ensured that clinicians have access to our brochures and education materials. We've estimated that the total cost of delivering the program is approximately $350 per patient. And we've developed a partnership with Spinal Cord Injury Ontario to provide access to the therapist-delivered program to approximately 130 participants per year for free. And of course, a self-directed program doesn't need any additional funding. Another important area that I think is important is evaluating impactful research is designing studies and programs that target the underlying factors associated with their well-being and long-term engagement in healthy behaviors. And as I previously mentioned, chronic pain is a condition a person has for the rest of their lives. So really thinking about how we target some of those factors that influence long-term engagement in healthy behaviors. And so when I think about long-term maintenance of healthy behaviors, there's two things that come to mind. One is examining and targeting underlying factors that are associated with long-term well-being. And the second is ensuring that the strategies we're using result in healthy behavioral change over the long term. So for my own research, looking at underlying factors that affect long-term outcomes amongst chronic pain patients, I really wanted my digital health programs to target factors such as experiential avoidance and pain catastrophizing. And additionally, when we look at models for long-term engagement and healthy living, we see how important psychosocial factors are in initiating and maintaining healthy living. So factors such as risk perception, outcome expectancies can really influence if a person's going to decide to engage in an intervention or in healthy behavior. And so really ensuring that when we develop a program, including psychoeducation about how the program can benefit the individual can be important. Additionally, individuals' efficacy in coping with stresses and recovering from lapses can be important to maintaining healthy behavior. So really teaching skills that help patients recover from lapses is important. And then when developing content for my interventions, I also wanted to look at an area of research amongst the blue zones, where there's great evidence for activities that result in long-term engagement and healthy behaviors. And blue zones are geographic areas that have lower rates of chronic diseases and longer life expectancies. And so when we look at the activities people are engaging in the blue zones for long-term healthy aging, they aren't necessarily prescriptive or structured. It's things like gardening, walking, engaging in social activities. So in these blue zones, well-being and activity engagement is thought of as a way of life. It's a culture that's being adapted, and it's everyday activities that connect individuals socially and develop a sense of community. And I think that's important when we keep in mind when we develop interventions for long-term engagement, really helping people change their mindset and develop skills that allow them to integrate healthy behaviors into their life and maintain activity and participation over the long run. And so based on these findings, I really made sure to implement activity strategies that aren't always structured, but can be easily incorporated into daily living, into the program content of the digital health interventions. And also sometimes treating the individual doesn't always work. We have to think about the individual's network and the importance of developing a sense of community. So really targeting not just the individual, but the family and also the community networks. And so we also want to target some of those factors that we talked about. So things like activity avoidance, coping, and recovery self-efficacy, because people will always lapse. kind of like we do when we're trying to, adapt a new healthy lifestyle. So being able to kind of develop the skills on how to engage in activities is really important. So content like relapse prevention strategies can be important to incorporate. And so when we incorporate these ideas, what we found is significant improvement in factors such as self-efficacy, ability to participate, satisfaction with participation, satisfaction with social roles and activities. And lastly, I'm really interested in exploring research on what we do with non-responders and disengagers. If we want to have impactful research, how do we follow up with participants that don't respond to the intervention and potentially provide a stepped-up approach to care that we would normally do in a clinical health setting? And I think this really mainly speaks to the limitation of a traditional RCT design. So in a traditional RCT, patients are randomized into specific groups, and in order to ensure validity and reliability, specific protocol needs to be followed. And this means that for some people that are not responding, we're not able to use our clinical judgment to step up care as needed. So how do we conduct research where we can have pre-planned changes to protocol without affecting the validity of the study? And I think this is where using adaptive study designs might be helpful. These research designs often involve pragmatic approaches that allow for pre-planned adaptations. And these approaches are great because they allow us to design research trials through a pragmatic approach that can be used in clinical practice. So for example, when you have a patient that's not responding to a particular treatment, you don't just let them go, you follow up and you try different strategies through a stepped up approach in clinical practice. And so one way I've incorporated this is through an adaptive study design called SMART. Here, the study will first randomize eligible participants to a self-directed or a therapist-guided online well-being program. And then at 6 weeks, where we usually see participants showing a response to the intervention, I'll assess who's responded to the program and who hasn't. And those that have responded to the allocated program will continue to be monitored and followed up. And those that are non-responders will be re-randomized into either a modest step up or a vigorous step up. And this allows us to create a more pragmatic trial, allowing us to provide stepped up care for those that need it within the RCT framework and maintaining that validity of the trial. What about those that are disengagers before they can actually benefit from the intervention? And so one strategy that I've recently started looking into for this is really based on research evidence of gamification to engage users as they learn and achieve their rehab goals. So recently, my team has been developing and piloting an app that aims to improve cognitive, mental, and physical health of those with neurological conditions through games that require physical exploration and social cooperation. And really, the main aim is to help build a sense of community amongst those with neurological conditions. And we've kind of created the infrastructure of the app, but we're kind of working on the graphic user interface at this point, and kind of pilot testing some of the augmented reality frameworks to use. And then just in summary, my aim is really to continue developing expertise in digital health through my background in patient-oriented research, implementation science, and adaptive study design. I primarily want to look at aspects of digital health that really show us how we can improve health services and shape health policy. But also other areas of my research include examining human factors such as safety and usability of digital health interventions, and evaluate design factors such as gamification and persuasive designs that help engage users on digital platforms. In terms of what's next and potential collaborations, currently we have a few ongoing studies. So I have a couple of online internet-delivered cognitive behavioral therapy trials, one in stroke, spinal cord injury, care partners, and tinnitus. And then I'm going to be submitting a new grant to look at this program in high-dose opioid users and also an augmented reality game. And I just wanted to take a moment to kind of acknowledge my mentors and kind of borrow from Dave's quote. I feel like a jack of all trades and a master of none. And I'm really grateful to my mentors for really showing me how to thrive in the rehab world by embracing the chaos that exists. And I think in the end, all we really want to do is make sure, we're helping our community using scientifically sound principles. And I'd also like to acknowledge my students and staff for supporting me, and of course, my funders. And I'm happy to answer any questions that anyone may have. Thank you.
Thank you, Swati. Really great overview of your work, and nice to see where it's headed too. Questions from the audience? How?
Thank you very much. I really enjoyed the talk, and I'm a bit in left field in all of this because I'm a qualitative researcher. Okay, so the question that comes to my mind is, I just wonder, there's this sort of cloud of psychosocial elements in both presentations. Psychosocial was talked about in both presentations, but in your presentation specifically, I just wonder, the notion of healthy behavior and lifestyle. Lifestyle wasn't mentioned, but you talk about healthy behavior a lot, and so healthy behavior is very culturally specific. So if you suffered a spinal cord injury and you're living in a rural county like Wicklow in Ireland, healthy behavior might be going to the pub and having 4 or 5 pints of Guinness to talk about your pain, and that might be culturally seen as appropriate on a Friday night for that sort of behavior. But I'm assuming that's not the kind of healthy behavior you're talking about. So how, in fact, are you defining health in your research?
Yeah, that's a really good question. And I think when we talk about what you've mentioned, healthy behaviors, it's not just about the traditional sense, because the example you used, in a way, it is healthy and adaptive because they don't have other sources of social connectedness, right? And so in a way, they're going to a pub and connecting with people and venting and talking about their issues. And there's not necessarily anything wrong with having a drink and connecting with people. And when we think about things like harm reduction, right? So incorporating those kinds of ideas into healthy living lifestyles is part of what we do. And so if that means instead of having 5 drinks that day, just having 1, but still being able to connect with people, we would still consider that healthy behavior. And so when I talk about health, I don't necessarily mean it has to be this perfect idea of doing everything correctly, but being able to kind of use the resources that you have in place to kind of move forward and improve your health.
Thank you very much.
Swati, if you don't mind, I might pick up a little bit on that thread. And first of all, terrific presentation. I love to see what you've done and where you're going. And I saw that little figure of a dog at the end that said you still have no idea what you're doing, which I think your presentation clearly disagrees with. I think you're taking some really interesting and exciting directions. On the topic of, I guess, what you were just describing there, I had sort of 2 related questions. And it was, my first question I wanted to ask was around, for the first part of your presentation, the educational or the behavioral interventions, was just how customizable are they? Like, if you know what I'm getting at, sometimes these things can be sort of like, here's some pamphlets and here's the recipe book and you follow that. And I think as Dr. Howe just described, that doesn't align with everyone. But I think there's even a broader question here, and that is just this idea that, so often we place disability or pain or whatever inside the person, without really looking more at the broader sort of social context within which it occurs. And so I guess I'm not sure how to phrase best the question there, but more like getting at this idea of like, to what degree either can you or do you see it important to enable that adaptability and customization to the context of the person within the social world that they live?
Yeah, I think that's an important question. And one of the things that I engage in is this podcast called Obstacles and Disability, where we talk a little bit about, how the social construct of disability, as you mentioned, is, internal. But really, if we think about the idea socially of disability, it's the barriers that society in a way has placed on the person that has the disability. And so part of what we like to do in our lab is also educate not just the individual, but the community on, reducing that stigma of disability and that idea that just because you have that disability doesn't mean you don't have a purpose in life, you don't have anything you can give back to the community. And so really engaging and providing leadership opportunities for people that have disabilities is an important factor. So in my lab, our therapist that I showed Wallace is a person with lived experience. He's had spinal cord injury for 35 years, and he's in a leadership role, really kind of showing people as he's kind of treating them or providing therapeutic guidance that, there are societal limitations to your disability, but there are ways that we can embrace that as well and kind of provide a healthier living to others and purpose for others. And then in terms of, how much can we adapt a lot of that material, one of the trials that we're looking at, and that's the tinnitus trial, is looking at how can we look at personalizing some of those features that we have, some of those components that we have in the ICBT trial to meet the needs of the population. So one of the groups is going to be standardized. So it's just they receive all the modules, as opposed to the personalized group where they receive specific modules that pertain to them particularly, and seeing how we can better personalize to the needs of the population.
Lovely. That's really neat. I like those designs. I see Naveen's got a question, so I'll move on to him.
Yeah, great presentation, Swati. I'm really interested in your work. So like I do clinical trials, and a lot of our clinical trials are adaptive trials with Bayesian analyses. And one of the things that we find very challenging is that, at Western, I think we're a big pragmatic trials hub, and it's very challenging at least in the clinical sphere, to marry adaptive trials and pragmatic trials. They're often quite disparate, and the reasons why is because if you have something that's a pragmatic trial, you may not be able to get all of the information to inform a decision point to adapt the trial. For example, if you're thinking whether I need to drop a group, or I need to reestimate a sample size, or I need to reallocate a participant to a particular intervention, you may need information that is over and above that of clinical practice. So therefore, your trial is no longer pragmatic, it's mechanistic. So, I'm very interested to know how you navigate some of these challenges and how you find a niche that is both pragmatic and adaptive.
Yeah, that's a great question. And I'm still kind of navigating those kinds of issues as well. So I work with statisticians, so GY here at Western, to kind of help me navigate those. One of the things that we really do is when we're doing the pilot trial, those are some of those questions that we try to incorporate quantitative and qualitative work into that pilot trial, so that we can look at what some of those decision points might be, looking at response and some of the stepped up approaches we might need to take depending on that. So I think designing that pilot trial really helps guide that next stage adaptive trial as well.
Thank you.
All right, thanks so much, Swati, and thanks everyone for being here and participating in the discussion as well. And thanks, Siobhan, again for the first presentation today. So this will be available. The recording of this session will be available on our website, like we do for all the Meet the Team sessions. So please feel free to share those with your colleagues who weren't able to attend today, and have a look back at previous ones if you missed them. We have a few speakers lined up for upcoming Meet the Teams, but if you are interested or if you'd like to hear from anyone on the team or anyone at Western or affiliated hospitals, just reach out and let us know. We will next be formally meeting with everybody. Hopefully, we will see you all on March 31st at our kNOw-PAIN conference. If you haven't seen that, there's the link in the chat. Thanks, Felix. Oh, those are the recordings, but you can also go to the website and see the link to the free registration for the conference. We hope to see you there. In particular to our clinician colleagues, we understand that making it to a full day event, given your very demanding schedules, is often difficult. So if you can make it for the keynote lecture, the lunch, the socializing afterwards, or any part of the day, still feel free to register and join us for whatever part you can. So with that, I think we will sign off unless, Dave, you have any additional points to add.
No, just remind, when we say lunch, that's a free lunch.
Free lunch.
If there's any way to get academics out,
Yeah.
free lunch. Thanks, everyone. Thanks to the speakers. Terrific today.
See you all next time.
All right. Bye, everyone.